Thank you for having me today in this meeting, and hopefully we'll all learn something new. And it's been a long time me presenting this kind of presentation, so please bear with me. So I wanted to talk about MDS because this is more recent, that not really recent, but it is more recent in terms of diagnosis as compared to other hematological diagnoses that we have. And another reason I wanted to present this is it's more confusing also, because the range of what we have put in this diagnosis varies all the way from leukemia, AML, to bone marrow failure syndromes, and anything in between, we have put them in this basket. So hopefully we can, so it's a wide range of symptoms, wide range, but general criteria that we try to include in this syndromes, myelodysplastic syndromes, there are 3 of them. My first one is most of them are acquired unless it's childhood, which is in the pediatric age group. So for us, most of them are acquired in adult life, and whatever abnormalities we are seeing in the blood. The specific criteria is clonal hematopoiesis, meaning there are abnormalities in the DNA of the DNA makeup of the cells. And then another criteria is all of them, there is more than one cell line involved with cytopenias. So anemia stays the main criteria, but it can be associated with either neutropenia or thrombocytopenia. Thrombocytopenia being the rarest one, but it can sometimes present isolated thrombocytopenia too, which is again very rare criteria for it. So we have to meet these 3 inclusion criteria to be classifying anything as MDS. And of course, the severity is what decides when we are going to be treating it. And that I'll go to that at the end of the thing. So dysplasia is the most important when we are looking at this dysplasia. Dysplastic cells are telltale diagnostic of it, but there are few exceptions to it. And again, I'll elucidate that towards the end. So I'm looking at it from the perspective of somebody who's practicing in the community, and they see a patient coming with the abnormal CBC, and they're trying to figure out what are we going to do. So in those situations, if we see somebody having anemia, neutropenia, thrombocytopenia on their CBC, and the doctor is concerned or the provider is concerned that they need to be evaluated, that's where they'll start. Right? So, and of course, these blast count, we would not know upfront when we are seeing the CBC. This would only come into account when we are doing the bone marrow. But by definition, the blasts have to be less than 20% in the bone marrow to be able to. So MDS is a diagnosis which is only going to be made after the bone marrow biopsy is done. So when the provider or the referring doctor is sending the patient, they would only have CBC with them to guide their referral. And
so real quick, I found 2. One was in Springfield and one was in Willows. Do you know which one you were trying to previously get to?
No, I have absolutely no idea.
So
Dr.
here's
Austin.
my assumption as well. You haven't been in it in 1,000 years.
Hi, Dr. Austin.
1,000 years.
Not really.
Uh-oh.
We haven't been in it in a while because you've used your laptop. Both of them were sort of in our first generation pool and infrastructure. We have newer pools that are done
Go ahead and
updated, and they're on newer infrastructure. I can give you a new virtual machine here or from Springfield if you'd like to have that as an option. You can connect to it just the same from anywhere, but it's going to be a new one.
Okay.
Okay.
Yes, please.
All right.
Probably from here.
Okay, that's fine.
It seems like Willows is actually where I use it the most. But
should I continue?
doesn't matter where I use it.
Yep.
So here would make more sense, I suppose.
I will assign you and title you this afternoon. We'll get you set up. It's pretty quick.
Okay,
Cool.
great. Thank
Okay. Sorry about it. So clinically, most of the patients are asymptomatic, except fatigue is the most common. Everybody has some kind of fatigue, and especially this presenting in our elderly population, they have fatigue from other reasons as well. So not anything guiding symptom-wise. And other important thing to keep in mind is because of the cytopenia, especially neutropenia, they are at high risk for bacterial infections. And sometimes if the ANCs are low, it's a good idea to cover them with antibacterial prophylaxis. Usually not so much fungal or viral or mycobacterial, but because unless they are immune suppressed for other reasons. But bacterial infections are the most important one to make sure they're, and that's one of the reasons for mortality as well. So etiology wise, MDS, we have 80 to 85% MDS cases are idiopathic, meaning we don't know the answer. We don't know why they happen. And about 10 to 15% cases are from DNA damaging agents, such as chemotherapies, which we have enlisted here, cyclophosphamide, chloro. So if patient has a history of exposure to chemotherapy or having taken chemotherapy before, this is important history to keep in mind, please. And ionizing radiation, which are again DNA damaging, environmental exposure to hydrocarbons, all those are causing the same issues. And so these are something to, when we are taking history for the patients, we need to keep in mind. And of course, direct link to exposure and manifestation of the damage is going to be difficult, but as long as we have the history behind and we have the documentation of these damages that have been done in the karyotype in form of complex karyotype or 3 or more acquired chromosomal abnormalities, specifically abnormalities of 5 and 7 or TP53, which are very suggestive of treatment-related MDS. So if we have those, then we can straight away say that this is from this reason we have it. And of course, the prognosis and our treatments are a little different in treatment-related MDS versus the standard MDS, de novo MDS cases. So let's go to the next one. Again, MDS incidence is not that high, but when you get to the older population, 4 out of 100,000 population, 4 people would have MDS usually in their 70s is the median age. And most of them are male predominant, except 5q deletion syndrome, which is more common in women. It does have better prognosis and better treatment responses to some of the treatments which we have. We'll see down when we read more on that. Other things to keep in mind while thinking about MDS is hepatosplenomegaly and lymphocytosis. If you're seeing that, then MDS is not likely going to be the diagnosis. And rare manifestations of skin manifestations are rare, such as in Sweet syndrome, but not common. And most of the time, the thalassemia-like presentation can happen in infusion hemoglobin H disease, which are very telltale characteristic peripheral smear, which show almost like little cannon tennis balls stuck in the cells, which again, those are rare things. I'm just mentioning it, but for the purpose of clinical community medicine, as long as we can say that we have those CBC manifestations, we have we are excluding out any other causes, then we can go to the next step. So here, there can be other associated things which we can see, but which can distract us from the diagnosis. But as long as we are aware that they can be there, we don't have to really get distracted. So there can be manifestation of hypogamma-globulin versus hyper. Either direction it can go. You can have polyclonal gammopathy versus monoclonal gammopathy associated with MDS. But again, it doesn't mean much. We still have to stay focused on what's happening to the CBC when we are looking at it. And another interesting thing to remember is we have a lot of autoimmune disorders in our community wherever we are. And autoimmune manifestations of hematological manifestation of autoimmune syndromes can sometimes resemble MDS. The only thing is dysplasia is not as much there. So autoimmune diseases can have peripheral smear pictures like resembling MDS morphology wise. And rarely what happens is when you have advanced MDS, 10 to 20% cases of high risk MDS can have autoimmune secondary problems as well. So it goes in both directions. Just as a to keep in mind, especially when we are looking at that, it is maybe part of the whole autoimmune syndrome in itself. So next, when to suspect the diagnosis are like that's where we are looking at from the community perspective. We have the CBC, we abnormality, we already know we are seeing anemia, neutropenia, thrombocytopenia. MCV is usually higher than 10. And there are usually some left shift, which we see, but obvious blasts we are not seeing in the peripheral smear usually, unless it's almost getting close to AML diagnosis. So usually when we are having the peripheral smear CBC pictures, if you look at the immature cells or blast cell count, they usually are very minimal. But if you see a lot of it, then definitely more likely to be leukemias. So again, thrombocytopenia is a rare manifestation, unless it's because of deletion 20, which has minimum dysplasia. And thrombocytosis also is a rare manifestation. So platelet abnormalities are much rarer as compared to the other two, like I mentioned earlier. So, and there can be features of reactive lymphocytes, which can be there because of other situations. So, but bottom line we have to remember is CBC is not going to be the way to make a diagnosis. CBC is going to only help us lead to get the patient to the hematologist so they can do the further workup to get the diagnosis established. And about 50% of the MDS may have some fibrotic changes in the bone marrow, which can be sometimes seen as teardrop cells and other morphology on the peripheral blood. So before we start worrying about the diagnosis of MDS and talking to the patient about it, I think it's a good, prudent way of checking the correctable things which can cause dysplasia similar to MDS. And some of them are vitamin B12 deficiency, folate deficiency, and even copper deficiency. There are toxic etiologies such as zinc, arsenic, and lead. And especially in this COVID time, recently we've noted much more of this zinc toxicity happening because a lot of people were taking excessive amounts of zinc to protect themselves from COVID. And we landed, I myself have seen several cases in my own practice here. So something to keep in mind. Other medications which can you can see similar morphology, the Neupogen or Neulasta use for some reason, or other GCSF use, INH, alemtuzumab, and these are all list of these ones, chloramphenicol, clotrimazole, tacrolimus. These are all immunosuppressive medications. So a patient must have had some other thing going on, which we need to keep in mind if these kind of medications are being used. Ganciclovir is pretty common in community, so something to keep in mind. And valproic acid use is pretty common in patients with MDP, and long-term valproic acid use is being used there. So we need to keep that in mind. Excessive alcohol use with cirrhosis diagnosis is also masks the MDS sometime, and we need to make sure that that's excluded or checked out. Acute HIV infection and viral syndromes preceding the abnormal manifestations on the CBC, something to keep in mind because they can present exactly like we are looking at here. Rare hematological manifestations of autoimmune diseases such as lupus, which we elucidated earlier. So these are some of the things that you see. This is a picture just showing abnormal cells with high platelets and a lot of clumped together, a lot of groups on this. Multiple small lobes and some. This one you see abnormalities in the red cells, a lot of abnormalities here, different shape, size, and clumping. And then you see the granular, these are WBCs, hypogranular WBCs with small lobes, hypolobe situations. And this is the same varied manifestations which you can see when you get the peripheral smear report from the lab, and they would be elucidating all these things which we, of course, most of us don't know what they are meaning, but they are all different abnormalities. Just to, and I'm sure all the residents, they know what this is, right? So the elliptocytes, acanthocytes, all these are cellular abnormalities which we are seeing, and but none of them, the important thing to remember is none of them is diagnostic of any diagnosis of MDS. So even if we find these in the slides, it adds to the picture, but it's not confirmative or diagnostic in any way. So that is something to remember. There can be other reasons, explanations for people having these similar findings. Then, so like I mentioned earlier, diagnosis of MDS, bone marrow biopsy is essential for the diagnosis. And it can usually be normal cellular marrow or hypercellular marrow. Rare situation of hypocellular marrow are present in aplastic anemia with MDS overlap, or hypoplastic MDS, which you can see those, but otherwise mostly normal cellular or hypercellular for age. Again, these we just talked about. So second, we usually, when we do the bone marrow biopsy, I always say there are three parts to it. The morphology part, which we just discussed here. Then there is flow, which itself is not good at making diagnosis, but it helps to exclude other common diagnoses, especially lymphoma, myeloma, and all those. So that's helpful there. And then cytogenetics. Cytogenetics are when we, So cytogenetics, chromosomal banding techniques can pick up abnormalities in about 50% of de novo or MDS, and that's easy. So it's one slide, they make it ready, and then any main chromosomal abnormality, we can have the answer pretty quick. FISH is more specific and group of known MDS diagnostic mutations. Those ones we can check with FISH, but otherwise its yield is very less. And if you have FISH positive and other criteria not meeting, then we don't know what to do. So FISH is only done when we are not, after we have already, so stepwise, we have to check the chromosomal cytogenetics first, then going to the FISH. And then this 5q minus syndrome. This is a specific type of syndromes, or you can say a subset of MDS, which is mostly in women. Notable abnormalities 5q minus deletion, and it's much less aggressive. Overall, prolonged survival, better responses to treatment. So relative to rest of the MDS, this is a separate subgroup, which we all need to know to get, because it gives good response rates, CR rates, and people do very well with this. So next, the other newer techniques that we have in terms of identifying or the diagnosis of MDS is molecular mutation panels. We have we can check with PCRs, which multiply the abnormalities, or we can have different companies nowadays have target gene panels available, and most of them range between anywhere 25 to 40 of genes which they are checking. And the good part about these panels is it has a good negative predictive value, which means if these molecular mutation panel are negative, we can safely exclude the diagnosis of MDS out and look at other options which can explain our findings on the patient's blood. So that is important reasons, and they're getting, they used to be very expensive, but they're getting better as days are going. So hopefully we'll be able to run these on most of the patients when we are looking at the diagnosis. Other thing, important thing that we can pick up on these are mutational panels are these abnormal mutations, and such as TP53, which is very aggressive. Overall prognosis is bad, and we know that stem cell transplants in those patients does not succeed well. So it's good to know ahead of time with these techniques what we are heading into. So I want to take from here, once we have done the bone marrow biopsy and we have all this information that we are seeing here, then we can start looking at how to prognosticate. And I think that's where the time we need to start talking to the patient, because once you have sent the patient to the bone marrow biopsy, they're coming back to see you, and then you need to reveal what the findings from the bone marrow biopsy are to the patient. And there are two of these prognostic scoring systems we have. The initial one was actually in 1997, then they improved on it, and we have a formal scoring system in 2007, which included cytogenetics also in it. And it's been updated into 5 categories in the recent one. So let me just take you there. And again, it's mostly scoring. So it gives you this score here, and then these are the 5 things that you have to, from the bone marrow biopsy report, you write it on this, and then you can come up with a score, and it divides this initial score, divides it into 4, low, intermediate 1, intermediate 2, and this gives you how long the expected survival for the patient also is there. So this is a standard one. So it's good to have this card at home or wherever, not at home, I mean, yeah, in your office when you have it. And this can help calculate. Nowadays, there are a lot of, these are available online also. So you can directly put it in the scoring system and give the prognosis and this information to the patient as well. This is the updated one that we have, and it included more genetic information added to us and made it more, the scoring was allotted more, numbers were increased. So as we were learning more about the MDS, the genetic problem in MDS, and these were updated. So this is the updated one from 2017. And again, you can see how this is impacting, because overall survival ranges anywhere from 0.8 in very less than a year in a very high risk group versus around 8-10 years for low risk group. So these scoring systems help us kind of see ahead and at least give some idea to the patient what they are looking at and what needs to. Some patient may choose not to do anything if it is a low risk, and if their cytopenias and anemias are not severe enough, even with the diagnosis, sometimes we choose not to treat. And the reason being, you have to decide whether the treatment is going to be helpful for this patient or it's going to be detrimental. So sometimes, even if though we have the diagnosis, we have some options for treatment, but there are other factors which can be associated with poor outcomes in these patients. So just to keep in mind that patients, everything being same, patients with advanced age, comorbid conditions, poor performance status, and increased blasts, severe cytopenias, and who are needing transfusions, anything less than 8 weeks, they're all high risk, and overall outcomes are poor in those patients. So this is some caveats basically that I just wanted to keep in mind. MDS, if you have these mutations, even in absence of dysplasia, the MDS diagnosis is there. So this is these two mutations, SB31 and deletion 5q with one more mutations. These two are MDS defining criteria, even without it as dysplasia. This is the exception to remember in the beginning, we were talking about you have to have those three criteria: cytopenias, dysplasia, and acquired clonal mutations. This is an exception to that. So if you have these two, but you don't have dysplasia, even then the diagnosis can be made on that. Similarly, these are the mutations. If you have these, you find this on the bone marrow biopsy, and you were suspecting MDS, but if these mutations are present, and then they directly become acute leukemia rather than MDS, because the severity of the clinical course is such. And there are actually targeted therapies available which can give CRs much better, and they need to be treated right away in this situation. So these are our list of things: 15, 17, which has very good prognosis, inverse 16, translocation of 16, and translocation of 8 and 21. These are the ones that we have good prognosis. RUNX 1 or previously AML-ETO, this is not so much, but at least having the diagnosis of AML leads the patient to get treated sooner than later, which is what is needed here. Then going to the important thing about leukemia and myeloproliferative disorders is we have a lot of translocations, gain of losses of chromosomes, but MDS, usually we see more, instead of proto-oncogenes, which causes cell proliferations, we see more hypomethylation, DNA methylation alterations. And that's so overall, if you think of it, these mutations are accumulating from early few mutations, and then they are added up in MDS, and then more mutations are added up as we go towards AML. And so addition of these mutations are what is function-driven mutations, are what is later causing the changes in the morphology as well as the clinical presentation of the patient when we are seeing them. So these are some of the situations where you have you don't have the diagnosis of MDS, but you have other criteria which are being satisfied. And so you have clonal mutations, but you don't have the diagnosis of MDS. So this is almost, if you think of it, it's a step before the MDS diagnosis is established in the patient, and there are mutations collecting. So clonal mutations without any cytopenia or any other hematological condition, that's CHIP. And clonal mutation with cytopenia, and who don't meet any other heme malignancy criteria, then it is CCUS, clonal cytopenia of unknown significance, and single idiopathic cytopenia of unknown significance. We have no explanation why some cell line is affected like that, and it was not from childhood, or it's not considered from ethnicity based, then this is something, the diagnosis we can do. And again, keep in mind that none of these diagnoses, we are actually treating the patient with any intervention. We are monitoring most of the time, and repeating a bone marrow in future again to see if we can establish a diagnosis of MDS further down in timeline. So another rare presentation of, like I said, aplastic anemia, hypoplastic MDS, they are very similar in presentation, and both responding to immunosuppressive therapies and sometimes stem cell transplant. And there are newer clonal diagnosis, which is their proximal nocturnal PNH, which have a GPI anchored protein on the cell surface, and that causes hemolysis and hypercoags and cytopenias in these patients. But fortunately, we do have target therapy against these clonal cells, and that's it's very rare though. So it's not common, but we do check in clinical practice when we are seeing the group of all those three, hypercoagulability, cytopenias, and okay, so next. So there are some, actually there is a, there they have the, so there are some overlap syndrome. They don't nicely fit into the groupings that we've made for them. So some are outside those groupings and they are overlap syndromes. And you can see here that CMML, the criteria for CMML diagnosis is, then JMML, it's in juvenile population, atypical CML without the BCR-able mutations, and some which we cannot fit in any, we put it in this unclassifiable grouping. So, so we have diagnosed the MDS. Now, looking at the treatment options, and of course, like I said, without the bone marrow, it's difficult to diagnose MDS. So make sure the patient is seen. By excluded any reversible things. Number one, patient is seen and workup is done, bone marrow biopsy is done, diagnosis is made for hematology. Bone marrow, after the bone marrow reports and evaluation of all the prognostic criteria, scoring system, then we can decide, okay, do we need to treat this? So if the cytopenias are significant, causing clinical symptoms, yes. If the cytopenias are not, and patient has so many comorbidities alongside, we sometimes choose just observe. Sometimes supportive treatments in the form of ESA agents can be given in low-risk patients, and that seems to keep their numbers in safe range and have them survive in community without any problems. High risks, which simply means they have high, they have high risk of transforming into acute leukemia. And where is it? Yeah, so those patients need to be treated upfront with treatments available. And in the next page. And there are 3 FDA approved treatments. I'm missing one slide somewhere. What happened? Which are available for high risk MDS. One is Vidaza, or where is this? I'm sorry. Where did this? The second one is Dacogen, which is approved for high-risk MDS, though there is no survival benefit documented yet. Vidaza has survival benefit of up to 2 years transfusion independence and almost 16 to 20% CR rates. So that is our usually first-line treatment for high risk. And both of them are given, can be given intravenously versus subcutaneously. The third one, Revlimid, has been approved as a second line for high risk also. And one thing to remember is in stem cell transplant is the only curative options. Treatment-wise, we have no other curative options for MDS. So, and especially when we are dealing with our older patient population, it's after there are low intensity stem cells which are available to people around 70, but beyond 75 and above, it's difficult to get them through stem cell transplant. So we mostly rely on supportive care or chemotherapy options for them. So, and as we know, anemia being the most common manifestation, people are transfusion dependent, and anywhere from 15 to 20 blood transfusions can lead to iron overload in the system. And sometimes they need supportive chelating therapy. Though it helps bring the numbers down, it has its own side effects, especially kidney problems, especially in the older population. So sometimes it's not even worth doing it, and it doesn't have any survival advantage as well. In patients who are exclusively presenting as thrombocytopenia, which again is a very rare manifestation of MDS, it's helpful to try Promacta or that is the L2 bag, and the Romiplastin, that's the injections, which can help improve the platelet count. And if it is active, life-threatening bleeding, they can use the aminocarboic acids. This can be used, epsilon aminocarboic acid. This can be used in emergency ER life-threatening situations. So this is a this is just a little graph, a picture I got from on how we treat the, I can't make it bigger, but it gives all like a flow chart on how we decide what we need to give to what patients once we have the IPPS scoring system, and we can start from there. And then there is another one here, same for high risk ones, and it gives us our direction and treatment choice. So this basically is at the end. So going back to, again, the patient's diagnosis is established after the bone marrow biopsy. We discuss their prognosis at that time and offer them treatment options if they're available for them, and then rely on them to make the best treatment choices for themselves. If they do choose to go forward with some treatment while fully understanding the side effects of the treatment, then usually we can try, but most of the time supportive help is definitely can be done in most of them. So I can take the questions after this. Anybody has any questions, and we can go from there. Thank you for having me here.
So are there any questions for Dr. Dhanuka? Well, thank you so much, Dr. Dhanuka. I greatly appreciate you presenting today. And you have one of the largest turnouts I've seen. So
yes, thank you.
I think we should have more next time, because we need to, I'm going to try to see if we can get more people to come over, because it's good that we all learn from this kind of situations, you know.
Absolutely. And I plan to forward you, and I know Dr. Reese is also involved in the internal medicine. So I plan to send the flyers over to both. I did send them over to him as well. But
Okay.
the more we get added into this is fantastic.
Yeah, no,
Yeah.
this would be good, because then we can, and especially at the residency program, we can get those students also in. That would be very
Yes.
helpful.
Absolutely. Well, thank you for your time, and I'm going to go ahead and end the meeting.
Thank you. Thank you for having me. Have a nice
No,
evening.
Our
everybody.
pleasure.
Thank
Nice
you.
to meet.
Thank you. Thank you. Bye-bye.